So, Alex, I think you mentioned this earlier on that there are some newer drugs coming along. We saw some data, I thought some very nice data with brigatinib, and that's close to being an FDA-approved agent. Lorlatinib has evolving data. What's your perspective on these newer agents?
Yeah, so I like to call these drugs later generation drugs because we can't keep naming third, fourth, fifth. It just gets very crazy. The difference with these drugs compared to the second generation drugs is that they're better against the wider profile of these ALK mutation resistance mutations we talked about earlier. And lorlatinib, for example, can overcome the G1202R. For brigatinib, there's the ALTA data that was presented, which showed that patients did have a good progression-free survival on it. In fact, barring cross-trial comparisons, it was one of the higher PFSs that we've seen, and really deep responses on the waterfall plot. We've also, from ASCO, seen data on lorlatinib, not just in patients who have gotten one drug before, but two ALK inhibitors, where the response rate was in the order of 40%. So it seems like we may be moving towards a phase where we might have a third drug to sequence after the first two have failed. Obviously, the question of if alectinib becomes first-line therapy, what do you do next is a good question. Right. But it seems like a drug like lorlatinib that might hit the G1202R could be a reasonable choice after alectinib failures.
Yeah. So, and we have the ongoing, I don't recall the name off the top of my head, but brigatinib versus crizotinib, very similar to the ALEX and J-ALEX. Yeah. One of the questions I'd like the panel's opinion on is that each one of these agents in the phase 2 setting has focused on CNS activity. And again, this is phase 2 data, reasonably sized phase 2 data. Do you get a sense that they all have a level of activity in the brain? Do you think one looks better than the other? My feeling is brigatinib kind of looks better, but it also has the fewest number of patients on their trials, so that may inflate the benefit. Anyone have thoughts about that?
I think they all have activity, and brigatinib does look better by numbers. I think they also have done a very systematic approach. They had a very systematic approach in reporting the accurate numbers for response rate and progression-free survival, characterizing active brain metastasis versus not, measurable versus non-measurable. This is a whole evolving field, I think.
And doing it prospectively.
That's right. Yeah. So I think it would be important for us to be able to make comparisons, to have across the different drugs the same quality data that was produced from these studies, so that we could definitely pronounce an opinion on whether one looks better than the other.
Right. So, we discussed T790M and the importance, and I think Vali said it, it's, critical to rebiopsy, retest, whether it's tissue, blood, urine. Is in clinical practice today, is there a reason to rebiopsy an ALK patient, retest an ALK patient today in practice?
So I try to when I can.
But why?
Yeah, so the different ALK inhibitors that we have, as I mentioned, have different activity levels against various mutations. For example, just choosing between alectinib and certinib. Alectinib doesn't work against the I1171.
So if you knew that, that would be informative.
If I knew that,
would be informative.
I would think of doing certinib, despite the toxicity maybe start at 450.
Yeah.
But the problem is, since the mutations are all over the map, you need a more comprehensive test that takes a while to come back. So you're back in that same sort of arena.
Yeah. Tracey, your
thoughts? There are other mutations that can develop too that can sometimes be actionable. Like they've seen sometimes EGFR mutations and KRAS mutations. So those can be important to know about. I think I don't routinely biopsy on the initial progression event if I haven't gone yet to alectinib or ceritinib, if they just progressed on crizotinib. I did have one patient, though, who was very informative. And this was a patient on crizotinib who developed this strange waxing and waning inflammatory syndrome within his lungs. And it was so bothersome, we couldn't tell what it was. So we biopsied it, and he was having tumor emboli to his vasculature in his lungs that was causing an inflammatory response. So that actually represented progressive disease, even though we didn't see any other clear sites of progressive disease. And he was very symptomatic from this. the amount of tumor tissue we got from even a wedge resection of his lung was insufficient to do molecular testing because they were just microscopic little things. But I sent plasma testing on him, and we found that he had G1202R. So I was able to send him to Boston for one of the lorlatinib trials, and he's been on it for over a year.
Yeah. So Vali, your perspective on this issue of rebiopsy, or how do you sequence? I mean, do we have any trials that are going to address sequencing sorts of issues in the ALK space?
There has been a clinical trial that the NCI is sponsoring that has been in the works for several years now. The ALK Master Protocol that is still being designed to address these sequence questions. And this clinical trial, of course, would demand biopsies from patients that progressed and sequential plasma testing so that we can get this information. And I do believe that we need to at least attempt a rebiopsy for patients for the reasons that Tracey outlined, but also because we need a body of information to better characterize what are the resistance mechanisms. I have to remind everybody that the data we have is based on very small series from individual academic institutions, and there is no robust data. We need this data, so that could be achieved with an NCI clinical trial, or it could be achieved if we all agree that we need to collaborate in this setting to produce this data.
Yeah, I think I'm going to come back to Jared with, what his message would be to the community oncologists. When I speak to many community oncologists, they may see one ALK a year, two if they're lucky, maybe one every other year. It's, as we've talked about, it's an incredibly complex situation. There's an ever-expanding number of drugs and these sorts of things. What would be your advice to the community oncologists? Send them all to you?
Absolutely. Either that or Florida if North Carolina is too cold. So I do a lot of traveling, doing community lecturing, and I think the key message remains that it is mandatory to test for ALK in the first line, right? I think in this panel we sort of take that for granted. We move on. We want to talk about higher brow stuff. That is still a real issue in the United States, non-testing of ALK in the first line, that we do have an FDA-approved drug to action it, that can demedicalize the patient's life, that can have lower toxicity, longer PFS, that upon progression, this is not of all of the places where I'm going to push rebiopsy on the community. I think that with 2 approved drugs that most patients will respond to, that might not be the hill to die on. Right. That I think the bigger message is to use one of those 2 agents. And that after progression, these are patients that they should consider preferentially sending to an academic center to get rebiopsied and consider more advanced trials.